So on behalf of the European chapter of the Society for Psychotherapy Research, my name is Uli Kramer. I'm a past president of this organization. I'm really very delighted to see everyone for our second webinar. We have already met in March, and now it's the second time we have the privilege to meet, and of course new people join and so forth. For this new webinar today. This webinar is really the fruit of a work group I would like to acknowledge, and some of you are there. I see Larissa and a few other colleagues who have been, and Katerina, of course, and Larissa, who is translating today for us into Ukrainian. It's actually the channel Portuguese for technical reasons. Don't be too confused about that. So welcome everybody, heartfelt welcome to this webinar. We have had a first one on therapeutic presence, I believe for some where it's still available to watch. And also we also wanted today to have a webinar on a topic that may be a little bit more at the heart of the research that we are doing when we're looking at the effects of psychotherapy. So we weren't, of course, there's one expert in Europe that we really wanted, and we're very happy to have him here today. It's Professor Stігom Poulssenom from the University of Copenhagen at the Department of Psychology in Denmark. So welcome, Stig. Professor Poulssenom is, as expert in lots of research and lots of experience in assessing psychotherapy from a variety of perspectives. He has been looking at, change when patients with bulimic disorders have done psychotherapy, or also looking at psychodynamic variables across psychotherapy. Himself a psychodynamic psychotherapist, and will be teaching on choosing the right measure in psychotherapy. It's such a crucial question. I'm really delighted to listen to him. Today, of course, Professor Poulssenom is also past president of the European chapter of SPR. And I'd like to leave him the stage right now. Is there any technical things we need to do before, or just start? Any? Larissa, all good? Okay, turn it over to Stig.
So thank you very much for inviting me. I am delighted, somewhat humbled by being here together with you. I'm overwhelmed about the attendance, and I just, of course, want to express my sympathy for the situation that you're in Ukraine, and assure you that Denmark stands united behind your fight. And if this can somehow show some kind of solidarity with the situation you're in, I'm more than happy that we could be here, and I'm really happy that you have organized this initiative. So I will share my screen and go on to my presentation. So in a minute, you will have to tell me if you can see my screen. I just have to do this. So does it look all right to you?
It's good. Thank you.
Так, видно.
Super.
So yes, everything's okay.
Very good, thank you. So I heard that at the last seminar you had Sherry Geller speaking about presence in psychotherapy, and I'm sure it was really engaging from a clinical point of view. I am a little concerned that I may not be quite as emotionally engaging because I've chosen a topic that is admittedly rather dry, and that is what kind of outcome measure should you use for evaluating the outcomes of psychotherapy. But even though it is perhaps a little bit dry, it is definitely really important. So I will just, let you have it. I'm sure that a lot of you are clinicians. Some of you may be psychology students. Some of you may be researchers. I hope this will be relevant in some way to all of you. So as Uli said, I am professor of clinical psychology and psychotherapy in Copenhagen. And what I wanted to do was to give you sort of a broad introduction, an overview, so to speak, of measures that are relevant to monitoring the outcome of psychotherapy. And for that matter, also for other psychiatric treatments. So I'm not going to tell you about psychometrics, you know, the quality assessment of instruments, at least not very much. I'm not going to talk about the statistical issues in outcome measuring. I'm simply trying to give you some rules of thumb, some guidelines for how to choose instruments and what considerations you might want to have when you try to choose outcome measures. So I'm going to talk about a lot of different measures belonging to different domains and used for different purposes. But even though I'm going to talk about a lot of measures, there are so many more out there. So the measures that I will tell you about are only examples of instruments that have been widely used. They're not necessarily the best, but they belong to those that you might consider using for the specific purpose and context that you have. So before I go on with the instruments, just wanted to give you a little bit of perspective. So the discussion about outcome measuring can be seen within the context of the discussion of evidence-based practice versus practice-based evidence. So first of all, I would like to say that I am so old that I do remember when psychotherapy was considered something that was, you know, very experimental, definitely not an integrated part of psychiatric treatment, something that was frowned upon a little bit, at least by many psychiatrists. And the position of psychotherapy in mental health has luckily changed dramatically over the past 40 years. And at least in Denmark, I'm not quite sure about Ukraine, but at least in Denmark and in large parts of Europe and the United States at least. And probably the most important reason for this change is that a lot of research has been conducted. And this research has systematically been testing the outcomes of psychotherapy with well-established measures. And this has resulted in several psychotherapeutic approaches being designated as evidence-based. So even though this is not the only way to do research, to focus on what approaches are evidence-based, what types of psychotherapy should be used for specific disorders, it is something that has had an enormous importance in terms of establishing psychotherapy as a well-accepted approach to psychiatric and psychological treatments. So today, the ideal for evidence-based practice is often expressed with these three overlapping circles. So evidence-based practice is usually defined as using the best external evidence, and that is the evidence that has been provided by these types of control studies where you measure the outcomes in a valid way, but also to have this evidence combined with the clinician's individual clinical expertise and being mindful of patients' values and expectations. So it's not just about implementing specific evidence-based interventions. It is doing this, but with an eye for the specific context and the specific characteristics of the client. So another approach to research is what has sometimes been termed practice-based evidence. And that is research that is based on a systematic measurement of outcomes of psychotherapy that is conducted in real-life settings. And this will sometimes be at a therapist level, or it might be clinics that gather together evidence. And this is sometimes is typically not controlled, not randomized controlled trials, but more observational studies, more naturalistic studies. but it still provides a huge amount of information about psychotherapy, about the outcomes, and often also about the processes of psychotherapy. And this kind of research may be particularly relevant to those of you who work as clinicians and who might perhaps even be interested in monitoring the outcomes of your own psychotherapies. So outcome measurement is not only something that happens in as part of large research projects, it's also something that you can do within your clinic as an individual clinician or as a group of clinicians working together in a clinic. And I'll come back to that. And in this way, evidence-based practice and practice-based evidence may supplement each other, and both approaches may yield valuable research findings. But essential to both approaches is that you have standardized and validated outcome measures and that you're able to choose the right measure. And this depends on a lot of different factors, which I will try to share with you. So among these factors that impact what measure you should choose is the first question would be to ask yourself, what is the overall objective of my outcome measurement? So do I want to use it for research? And if I want to use it for research, do I want to use it for what may be seen as the evidence-based type of research? It's a little bit more top-down. You have hypotheses about the efficacy of a specific psychotherapeutic approach, for instance. Sometimes you may even obtain some funding, some financial funding for the study. You have a large sample of patients. They are ideally at least randomized, and there's an experimental group and a control group. And if you're lucky, you will find a result that can perhaps even document or strengthen your belief or the evidence for a specific type of psychotherapy. And if you want to learn more about those kind of studies, you could, for instance, get this great book, the Bible of Psychotherapy Research, Bergen and Garfield's Handbook of Psychotherapy and Behavior Change, and look into the chapter by Barkan and Lambert on the efficacy and effectiveness of psychological therapies. If you want to do a little bit more practice-based evidence, you might also want to consult a chapter in this book. It's one by Louis Cassinguet and colleagues that's focusing on practice-based evidence and on findings from routine clinical settings. So if you want to use the instruments for research, you may sometimes also have the resources for having, for instance, research assistants. You may recruit patients and maybe perhaps even able to give them a small financial compensation for completing questionnaires, for instance. And you may have sort of a larger assessment battery that you want to use. You may have another objective, and that may be that you do not necessarily want to use the outcome assessment for research, but you might want to use it for quality assurance. And this quality assurance can be at a service level, a clinic level. So it may be that a municipality, a region wants to evaluate does the psychotherapy that is provided or the psychiatric services that are provided, well, do they produce results in the way that you would want them to do? But you may also, as an individual therapist, want simply to monitor, well, how do my clients fare? Do they actually improve the way that I want them to, and that I perhaps feel that they actually do? And this is really relevant because quite substantial amount of research shows that even though a lot of us actually feel that we're doing a really great job with our clients, and obviously are that, then sometimes the results of the psychotherapies in terms of, for instance, symptom reduction is not necessarily as impressive as we would want it to be, and perhaps as we sense as well. So to systematically monitor your clinical practice and see if clients actually do improve the way that you want them to do can be really an eye-opener for you and can help you try and experiment with perhaps changing your psychotherapeutic practices, perhaps, you know, getting more supervision or whatever you would want to do in order to improve your psychotherapeutic practice. And this is also really relevant with regard to the specific purpose of outcome measurement. That would be to produce data that can be used for feedback to clinicians and clients. And I'll come back to this thing about feedback because this is something that is really interesting. How can we use routine outcome monitoring to continuously allow clinicians to gauge whether their clients actually do improve, and to establish some kind of measures with clients that do not improve in the way that you would want them to. So all these things are relevant if you want to choose a measure for psychotherapy. And all of this is also very related to the feasibility of the measure. So you might want to have a perfect measure that can illuminate all the dimensions of some kind of outcome, for instance, depressive symptoms. But then you might realize that if you want to have that measure, then it will be very time consuming, and this may not be realistic within the context that you're in. So you would want to look for a measure that is briefer and more realistic to use, for instance, in day-to-day clinical practice. And of course, you will also want to have a measure that is available. So which measures are translated? Can you actually perhaps translate measures, perhaps together with colleagues? Some measures are actually costly. You have to pay a fee for using the measure. All these issues you have to look into as well. And then the most important thing about choosing a measure for psychotherapy is probably, obviously, what does this measure actually focus on? What does it measure? So there are actually a lot of things that could be relevant to you as psychotherapists to know more about in terms of the outcome of psychotherapy. Because outcomes are obviously often thought of as symptoms. So if you treat a patient for depression, then you want to know, do the depressive symptoms actually decrease during treatment? But you might also be interested in the social functioning and the quality of life of your clients. So you might see that the depressive symptoms do not necessarily decrease all that much, but you can see that the client actually has been able to go back to work. You can perhaps see that the client will say, well, I realized that I can actually have some quality in life, even though I still fight with my tendency to depression. So outcomes are more than just symptoms. It's a broader concept than that. Another thing that you might be interested in is or are symptoms or are measures that actually measure something that is specifically relevant to the type of psychotherapy that you use. So if, for instance, you work as a psychodynamic psychotherapist, then you might have the sense that, of course, it's important to help a client with his or her symptoms. But the overall aim of psychodynamic psychotherapy is something that's larger than just getting relief for symptoms. It is much more about personality change. It's much more about helping the client being more open to experience, having more trust in relationships, and so on and so forth. And this means that you might want to have specific measures that are designed or suited for the kind of psychotherapy that you actually provide. And so I'm going to show you in a little while some of these instruments. Then you might want to have individualized measures, measures that are actually measuring the specific problems that the specific client have. You might be interested in satisfaction with treatment, which is something different from outcome, because you may actually be really satisfied with treatment without having much symptomatic change. And overall, you might be specifically interested in measures that can be used for routine outcome monitoring. I just mentioned briefly that in a clinic, as a clinician, you might want to systematically and repeatedly monitor the outcome of psychotherapy and get feedback about, well, how is the patient developing? And there are specific measures for that. So all of these domains, all these symptoms will take up the main part of my lecture, which measures are there for each of these domains. I just have to say that when you choose an instrument, you also have to be wary of from which perspective do you want to gauge the symptoms or the problems. Very often what we do when we evaluate outcome, we use questionnaires or self-report measures, simply because those are the easiest to use. You can hand the patient a piece of paper where you have 25 questions, and the patient will circle answers on a scale from 0 to 4, for instance. That is like the most used format. These days, it's becoming increasingly normal to have these questionnaires in an app format, so that you can fill in the questionnaires online, which makes them much more feasible to the clients. But sometimes you might want to have a trained observer to evaluate what are the outcomes of psychotherapy. So what is the status of the client before psychotherapy and after psychotherapy? And for a lot of different disorders, an observer may have a more valid picture of the condition of the client. For instance, personality disorders, you might not be sure that the client will be able to have a reliable report of his or her own problems. If you want to have an assessment of psychotic disorders, it can be hard to have clients reporting the outcomes themselves, and therefore you might want trained observers to use rating scales. You might also want to ask relatives, for instance, well, how do you experience that the client functions at home, for instance? You might want to talk to professionals, to teachers, etc. So again, when you choose a measure, you have to be wary of which perspective, from which perspective do you want to have the report on the condition of the client. So finally, you would also want to consider psychometric aspects of the instruments. This gets a little bit more complicated. This is not the focus of my presentation. So I just want to say that you can have a measure that looks like the perfect measure for what you want to evaluate, but it may not really measure correctly the phenomenon that you want to look at. And this means that you have to look into two aspects of the measure, two aspects of the measure's psychometric properties. And those two aspects are the validity of the measure and the reliability of the measure. So very briefly, in terms of validity, you may check, and that's not you who would check that, but you would want to look very much into the articles reporting of the psychometric properties of the measure. So have they checked for instance, predictive validity, which would be an answer to the question of whether the score on the measure at baseline, for instance, would that be related to the outcome of therapy? So does the measure something that has an impact on future aspects of the client's life? You might want to see if the measure actually is in agreement with another measure of the same phenomenon. So sometimes you have measures, you have questionnaires, and you want to see, well, do they actually measure, for instance, the symptomatic status of eating disorders or depression or whatever, in a way that is very similar to the results we get from a structured interview. And if you can actually have a questionnaire that can measure symptoms just as well as a structured interview, it's obviously much easier just to give the client a questionnaire. You also want to make sure that the instrument covers all relevant parts of the construct it aims to measure. So if you want to measure psychotic symptoms, then if you only measure positive symptoms and not negative symptoms, then you don't have a measure that has high content validity. And overall, you want basically the measure to behave like what the theory says a measure of the given construct should behave. So you might want, for instance, a measure of depression that is, that detects patients that are identified as depressive with a very high probability, but that would not necessarily have identified patients with anxiety as having loads of depressive symptoms. So you would expect it to be relatively high on anxious symptoms, but not just as high as on the depressive symptoms. And then you also would want to look into reliability. And you may remember from your training as psychologist that there are these various types of reliability. And all these things will be reported in the articles reporting results of the measures. So now let me try and show you how this can be done. So first, I would want now to look into these different types of outcome assessment, these domains of outcome assessment, and start first with the instruments that focus on symptoms of the various disorders. So what we have here are, first of all, measures that try to give a global picture of all the symptoms that a patient have. And perhaps the most well-established measure of sort of the global psychiatric symptoms is the symptom checklist 90. It was originally known as the Hopkins symptom checklist, and there are loads of different versions, typically a 90-item version, but there are also many briefer versions of it. And the really, really many studies of psychotherapy that has reported the results of the study as the score on the global severity index of this instrument, which is simply the average score of all these 90 items. And it's also a measure that has 9 different subscales. So it's a subscale on somatization, obsessive compulsive symptoms, interpersonal sensitivity, and so on and so forth. So there are a possibility to have more specific symptom profiles. These subscales tend to correlate really highly. So if you're high on somatization, then you're typically also high on the other subscales. But there is to a certain extent a possibility of getting a profile on what are the more specific problems of the client and how do they are they all reduced during psychotherapy. And it's a questionnaire that is simply scored on a 0 to 4 scale, where you ask the patient how much were you bothered over the past week by, and the first question would be headaches. So not at all would be 0, and extremely would be 4. And then, so score between 0 and 4 would be somewhere in between. The client fills that in. Then you're asked about how much were you bothered by nervousness, and so on and so forth. So this gives a relatively global assessment of symptoms. And there are loads of other these questionnaires. A relatively popular questionnaire is the CORE that is developed in the UK, which has 34 items, and the outcome questionnaire 45 developed by Michael Lambert and his colleagues in the US. And then there is a questionnaire that has been used increasingly recently called the patient health questionnaire, anxiety and depression scale, which actually has two sub-measures, one on depression and one on anxiety. And this is quite interesting because you may realize that in the UK, there has been a major overhaul of mental health services, in the sense that psychotherapy has been rolled out nationally as the treatment of choice for less severe mental disorders. And there's been implemented a stepped care program, starting with sort of very non-resource intensive interventions, such as internet-based therapy or counseling. And if this doesn't help, then you get a more intensive treatment like psychotherapy or counseling provided by people that have longer expertise. And then you may, if you don't benefit from this, you may have like specialist treatment by psychotherapy experts. And all of this has been evaluated by these two subscales, the PHQ-9 for depression and the GAD-7 for anxiety. And it's been used in Norway as well. And in Norway, they have actually conducted a proper randomized control trial of how does this approach to psychotherapy rolled out in large scale in psychiatric services or in municipalities. Well, how does it perform compared to standardized treatment, to the standard treatment, to the treatment as usual? And it has been documented that during this improved access to psychological therapies, inspired intervention, it helps people a lot more than the services that were used before. So if I remember correctly, I think 57% of the patients in the prompt mental health services actually responded to therapy, as opposed to 37%, I think, in the control group. So this is based on this very brief questionnaire, which can be used after each session, and therefore it can also be used to track how therapy develops over time. So you might also, besides these global instruments, you might also want to have more disorder-specific measures. And these exist for almost every psychiatric disorder. So one of the most commonly used instruments for a specific disorder is the Beck Depression Inventory. And the Beck Depression Inventory is a questionnaire that consists of 21 different areas or items. And for each of these items, you can rate between 0 and 3 to what extent is this a problem to you. So you have to state how you've been feeling during the past 2 weeks. For instance, regarding the feeling of sadness. So if you do not feel sad, you'll circle 0. And if you feel so sad or unhappy that you cannot stand it, then you choose 3. And this inventory, like many other inventories, have cutoff scores. So as a rule of thumb, you would say that if you have a score on this instrument from 0 to 13, then you would only have minimal depression or no depression at all. 14 to 19 would be mild depression, 20 to 28 would be moderate depression, and 29 to 63 would be severe depression. So you cannot use this instrument or this type of instruments to make a psychiatric diagnosis, but you can use them to gauge the severity of the depressive symptoms, and you can use them to monitor, well, do these symptoms decrease over treatment? So like the Beck Depression Inventory for anxiety, very often the Beck Anxiety Inventory is used, but perhaps even more popular is the State Trait Anxiety Inventory. And this instrument is consists of 20 items that assess state anxiety. So the questions would be, right now, at this moment, how do you feel? So do you feel tense? Do you feel worried? Do you feel calm? But you also have questions regarding state anxiety. That would be, so how do you generally feel? So do you generally feel that you, for instance, worry too much over something that really doesn't matter? Or do you generally feel that you're content, that you're a steady person? So this gives you the chance to measure both if, like, the more fluctuating feelings of anxiety change over treatment, but also if these more ingrained trait-based feelings of anxiety, if they also diminish during treatment. So for the PTSD area, there's been several instruments over time, but my sense is that there is a growing consensus that you would want to use as a questionnaire what has been termed the International Trauma Questionnaire. This has been developed specifically for the purpose of being useful and in accordance with the organizing principles of the ICD-11, the new diagnostic system that is being rolled out by WHO. And it's relatively brief. It has 12 items, 6 items that specifically focus on the PTSD symptoms, and then 6 items that focus on the new disorder, the complex PTSD symptoms, which are besides the sort of traditional PTSD symptoms that considers disturbances in self-organization. So, and besides that, you would have 6 questions about the impact of symptoms and functioning. And you can actually have some kind of diagnostic assessment using this instrument. So there is an algorithm for giving at least an idea about whether the patient actually meets the diagnostic criteria for PTSD. But you can also have severity scores that can be used for outcome assessment. So perhaps I should have a small pause here and just take a few questions. So I don't know if, I think I will stop sharing my screen just for a minute and ask you if there's somebody who have thoughts, considerations, questions.
Any questions so far? A lot of information.
Yeah, there's a lot of information. I know. So this is the hard stuff. But I hope you're hanging in there.
Right. Anyone who would like to ask a question? Or just say, continue. Should we continue without a question? Anybody maybe react?
Hello. I'm sorry I'm without video. I don't have a possibility to have a video now, but I can tell you that the PHQ, the depression scale and GET-7 is a very common use, like I see, like clinical psychologist in Ukraine now. And also I recommend to my patients when we end already our therapy, some online automatical these questionnaires, so they can monitor their state by themselves, and if they see that it's going worse, so they can go and ask for help or continue therapy. We have a very nice online site from Czech colleagues, Samopomich CZ, and they have there these questionnaires that in Ukrainian language, and people can just do it by themselves to screen their psychological state now.
That's amazing.
So,
and perhaps you could write a link to the instrument or some information in the chat.
yes, of course, I can do it. Yeah, of course.
So perhaps now that I have you and the rest of you out there, so how common is it to monitor outcomes routinely in Ukraine? Just, you know, I'm curious about that. I'm not familiar with the psychiatric and psychotherapeutic practices in the Ukraine.
Was it a question to everyone or Natalia in particular?
Actually, I think it was a question to everyone. I'm not sure whether it was translated.
Yes. Okay. Maybe it should be translated. If somebody wants to answer by chat or raising your hand, or, you know, there are multiple ways of answering or intervening.
We have the answer in the chat that it's typical, especially now. I have raised my hand already. We recently, the amount of objectivation of clinical research has not been such obligatory and such mandatory as right now. Clinical psychologists at their working places wrote their conclusions, but they researched those mental processes or functions that were important for psychiatrists, you know, or just to understand our results or consequences. But now we have lots of rehabilitation centers where the help is provided for people with PTSD, where the help is provided for people with depressive reactive disorders, where the help is provided for people who have some worries about losses. And that's why the amount of such structurized surveys, questionnaires that can show dynamic of the condition, it gets into rehabilitation center. For example, the person stays there for 1 month, and it is very important to objectify the change in his or her condition. That's why we have it more and more now. Practically all rehabilitation centers do not now have such questionnaires. They are widely used, and they become, you know, obligatory conditions of something that can prove effectiveness of psychotherapy. That's why, because of all the events that are now happening in Ukraine, because of the war, because of this popularity and massive usage of psychotherapeutic help, the questionnaire as proof of effectiveness has been used more and more widely. That's our current truth.
Yes.
Thank you.
Thank you very much. And I would imagine that there's also a huge strain on the resources of the psychiatric services. So that would also imply, I would guess, that you would want to have effective psychotherapies and hopefully relatively brief psychotherapies, which of course should be balanced to the severity of the conditions that I would assume that a lot of people are in. So it sounds as if it's, you know, there's really a practical need for assessment due to the very unfortunate circumstances. Okay, but I as I hear it, it's definitely a practice that you're familiar with. It may be less familiar to clinicians in private practice. I'm not sure about how used these types of outcome measures are, but we may get back to that, because if I continue at some point, we'll get into sort of how to use these measures in as an individual practitioner as well. Any more comments at this point? Okay, I think I will move on then. And share my screen again. Just so while this was examples of questionnaires, there are another approach to outcome measurement that is based on having trained readers rate the severity of symptoms. And perhaps the most widely used rating scale worldwide is the Hamilton Depression Rating Scale. So you have a manual for structured interview that you apply to patients with depressive symptoms. And for each of 17 items on the full version of the scale, you rate from a scale from 0 to 4 to what extent is the patient characterized by, for instance, depressed mood, being sad, feeling hopeless and helpless and worthless. And you would rate to what extent are these feelings absent? Are they only indicated if you sort of specifically ask about them? Or are these the feelings that are fully dominant, that this is the only feeling states that the patient reports spontaneously or verbally or non-verbally? So this measure has been used, as I said, very widely. Actually, a lot of psychometric studies seem to indicate that there is a 6-item version of the Hamilton D depression scale, which actually works as well, has the same psychometric properties as the full scale. And these are with the 6 domains of depression that can be termed the core symptoms of depression, which are depressed mood, guilt feelings, reduced ability to work and to be engaged in activities, psychomotor retardation, psychic anxiety, and somatic symptoms of general sense. And as with the Beck depression inventory, the Hamilton, at least the 17-item version, has cutoffs. So no depression at all would be a score from 0 to 7. Mild would be 8 to 16. Moderate depression would be 17 to 23. And severe depression would be 24 and above. And as you're probably familiar with, there are endless amounts of studies, psychiatric studies, both with psychopharmacological treatments and with psychotherapy that has used the Hamilton Depression Scale, both to see if the rate of symptoms is reduced, but also to see what percentage of patients are actually without depressive symptoms. So what a rate of patients are actually at a score between 0 and 7, and thereby defined as not having depressive symptoms anymore. So they would have recovered. So another instrument that I've been using quite a lot is the eating disorder examination. So the eating disorder examination is a scale that inquires into eating disorder symptoms, to thoughts about how worried are you about control of your eating? How worried are you about your weight? To what extent do you have, for instance, binge eating symptoms? So do you often eat large portions of food within a limited time? And of course, with these types of instruments, you would also be really interested in, well, if a patient says, you know, I eat a lot of food, and then you would want the patient to specify, so what do you eat then? And some patients say, well, I eat 50 grams of smoked salmon for breakfast, and the same for lunch, and the same for dinner. Then you would say, well, this is not what people would usually consider to be a large amount of food. But if the patient says, well, I eat 2 liters of ice cream and a whole toast bread, for instance, then you would say, well, this sounds like a binge eating episode. But the eating disorder examination also gives you 4 subscales on to what extent do you feel restrained, to what extent do you try to restrain your eating, to how concerned are you about what you eat, how concerned are you about your shape, and how concerned are you about your weight. So another rating scale that can be of interest to you and which has been developed relatively recently is the sister instrument to the International Trauma Questionnaire, and that's the International Trauma Interview, which is structured just the same way as the International Trauma Questionnaire. So like the questionnaire, there are 6 questions, 6 items that focus on the core PTSD symptoms, and 6 questions that focus on disturbances in self-organization to see if the patients also have developed complex PTSD symptoms. So there is a lot of research going on into these instruments, and they seem to have surplaced some of the more traditional instruments in this area. So the thing is, as I mentioned before, you do not necessarily only want to focus on symptoms. You might also want to focus on social functioning, on the quality of life, on these domains as well. And there are a lot of different scales that sort of fall into this overall domain. So among the self-report questionnaires, one that has been used quite extensively in psychotherapy research is the inventory of interpersonal problems. So the inventory of interpersonal problems is a questionnaire that has either 64 or 32 items. And these questions all begin either with, it's hard for me to, and it might be, for instance, it's hard for me to be firm when I need to be firm with other people, that is. And other questions begin with, these are things I do too much. So it might be, I trust other people too much. All of these items deal with problems that you have in interpersonal relationships. And the IIP is interesting because it is scored on 8 scales, and these scales, they lie within the interpersonal circumplex. So the interpersonal circumplex is a construction that has 2 axes. So there is a horizontal axis that goes from being too friendly to being too cold. So you may have problems that are related to being self-sacrificing, nurturant. So you might, for instance, say something like this, I let other people take advantage of me, so this might be a problem. And you might have problems being too cold, so that would be problems like, I find it hard I often find that I dislike other people. Then there are other types of interpersonal problems that lie on the vertical axis, and that is having problems being either too dominant or being too submissive. And the thing here is that this is based on the interpersonal circle, which was originally developed by Timothy Leary, who later became very famous as the LSD prophet of the 60s. But before he had that kind of career change, he actually developed the interpersonal circle, which is based on these 2 axes, the affiliation axis between being too friendly and too cold, and the dominant axis between being dominant or submissive. And Leary and other people with Leary had the idea that any kind of interpersonal interaction can be scored within this circumplex or within the circle, so that you may be both dominant but also quite friendly, and then you might, for instance, be, or what is termed here as being experienced as intrusive or needy. You may also be tend to be cold but non-assertive, and then you would perhaps have problems with being too inhibited. But you may also be cold and domineering, and then you would be more like vindictive and self-centered. So the inventory of interpersonal problems gives you a profile of a client, shows you in what domains do clients have problems. Do they tend to be domineering and cold? Do they tend to be self-sacrificing and non-assertive, or so on and so forth? And you also have the possibility of scoring these 2 axes. So are you overall more friendly or more cold, or are you overall more dominant or more submissive? So this is, of course, an interesting scale, because it's not only about symptoms in sort of the more psychiatric way, it's also about interpersonal style, interpersonal problems, and the way that you function in relationships. So this is also an outcome assessment scale that might be more interesting for psychotherapists that do focus on relationships, relational issues, and not only on sort of symptoms in a very narrow way. So another self-report measure that reports social functioning and quality of life is the WHO-5, which is a very simple scale. It can be downloaded easily, and it's about well-being. It's a well-being scale. So it simply has 5 items, and it focuses on well-being. So to what extent have you felt cheerful? To what extent have you felt calm? To what extent have you felt active and vigorous, and so on and so forth. But of course, this is not only a well-being scale, it's also a scale that tends to correlate quite highly with depressive symptoms. So if you do not have these feelings at any time, then you are probably also quite depressed. It's a very easy scale. It has very good psychometric properties and has been used for quite many psychotherapy studies as a primary or secondary outcome. So the measurement of stress is also really important in psychotherapy, and probably the most widely used scale is Cohen's perceived stress scale, that has 10 questions, very easy to use. It focuses on, for instance, in the last month, how often have you been upset because of something that happened unexpectedly? How often have you felt that you were unable to control the important things in your life, and so on and so forth. So you have cutoffs as well for which scores would be designated as low stress, moderate stress, high stress. And again, unfortunately, a scale like this might cover probably some of the general sentiments that would be the norm in Ukraine these days. But it is also something that, of course, it could be relevant in not only in psychotherapy research, but also as more general measures of public health, for instance. So another very widely used scale is the Sheehan Disability Scale. It's super simple. It simply has 3 items. And it focuses on to what extent do the symptoms that you have impact your social and work functioning. So this is really interesting because, of course, it's very interesting whether patients do have a large symptom load, but it's also really important to what extent they can function even while having these symptoms. So this is basically about, do symptoms actually make it impossible for you to go to work or school? Have the symptoms disrupted your social life? And have they disrupted the family life? So this may, for some, be more important and valid measures than the symptom measures themselves. So more global measures based on clinician ratings and not on self-report have been developed, and they have been part of at least the American diagnostic system, DSM-4 and now DSM-5. And in DSM-4, the previous version of the American psychiatric diagnostic system, there was this scale called the Global Assessment of Functioning that was actually included as an axis in DSM-4. And it focuses on social, occupational, and psychological functioning, and is rated by the clinician. So it's a scale that goes from 0 to 100. And if you're on the top of this scale, then you are extremely well functioning. So you would have superior functioning in a wide range of activities. Your life problems never seem to get out of hand. You're sought out by others because you have so many positive qualities and you don't have any symptoms. So this is obviously not very common, not among patients and not among any of us really. But then you can rate, you find ratings that sort of reflect more serious problems. Like, for instance, if you have a score between 40 and 31, then you would have perhaps impairment in reality testing. You might be illogical in your communication. You might be unable to go to work, to school. You might have problems in family relations, and so on and so forth. So this scale was intended as a scale that could be used for, again, assessing functioning rather than symptoms. So, of course, it's important to, again, measure symptoms, but you also want to measure functioning. The problem was that this scale was shown to have really limited reliability. So basically, clinicians had very different ideas about what would constitute a score between 40 and 31, what would constitute a score between 70 and 61, and so on and so forth. So it has been replaced.
Listeners,
I guess probably
training, but they have no groups to work on.
I'm sorry, somebody's microphone is unmuted and I can't hear you at all. Yeah, it's good now. They're muted. You can go on. Sorry.
Thank you. So the global assessment of functioning has been replaced in DSM-5 by what has been termed as an emerging measure that's called the HUDAS, the WHO Disability Assessment Schedule, and it actually exists as a self-report scale and as a rating scale that's rated by an interviewer, very much in the way that the International Trauma Questionnaire and Interview constructed, and it focuses on 6 different domains that are essential to functioning. So how is your cognitive functioning? Do you understand what other people say to you? Can you communicate? So to what extent are you mobile? Are you able to take care of your self-care, hygiene, dressing, and so on and so forth? Can you interact with other people without having problems with them? Do you attend to your responsibilities, leisure, work, and school? And can you join in on community activities? So this scale has markedly better reliability than the Global Assessment of Functioning and is probably intended to be the new internationally used scale on the measure of disability and reduced functioning. So for those of you who work and subscribe to specific approaches to psychotherapy, you might, as mentioned initially, want to have outcome measures that actually focus on dimensions of problems, of personality aspects that are central to the therapy that you are working with. So a lot of instruments have been developed either as outcome measures of specific psychotherapeutic approaches or as more general scales that seem relevant to these specific approaches. So, for instance, if you work with metacognitive therapy for depression, then the central focus of metacognitive therapy is rumination, the tendency to ruminate and the tendency to worry about rumination. So what would be relevant if you wanted to specifically test the outcome of metacognitive therapy would be to have a scale for rumination, because it would be, in a sense, a proof of concept of the theory behind metacognitive therapy if metacognitive therapy was particularly effective in terms of reducing ruminative symptoms. So you would perhaps, if you work with metacognitive therapy, you would be interested in using a scale on rumination for outcome assessment. So lo and behold, there are several scales on rumination. Probably the most widely used is the ruminative response scale, which has now been reduced to an 8-item version scale. But it's basically a questionnaire where the client is told that people think and do many different things when they feel depressed, and that they should reach each of these items and to see if this is typical of the way they act and react when they're depressed. And then the patient can rate if she almost never, sometimes, or often, or almost always thinks about how alone you feel, things, I won't be able to do my job if I don't snap out of this. Think about how fatigued you feel, how everything aches, and so on and so forth. So basically, is it typically of you to ruminate about the problems that are in your life? This would be the core target of metacognitive therapy, and therefore relevant to that kind of therapy. If you are a practitioner of dynamic psychotherapy, then you might want to see, could you find an instrument that would measure to some extent the more central expectancies and patterns of interpersonal relationships. And some of us who work with dynamic psychotherapy have been very interested in scales that measure attachment patterns. And probably the most well-established instrument for measuring attachment patterns, as a self-report measure at least, is the Experiences in Close Relationship Scale, which has 2 subscales. So there are 18 items that focus on attachment-related anxiety, or what some people term preoccupation, and 18 items that focus on avoidance. So items that would measure the tendency to have problems about being too distant from other people, the anxiety that you might feel if you're not close to other people. Could be questions like, or statements like, I'm afraid that I will lose my partner's love. I often worry that my partner will not want to stay with me. I often worry that my partner doesn't really love me. So these are questions that would indicate that you have a very strong need to always be extremely close to other people. On the other hand, you might have problems about being too distant from other people, to be avoidant towards interpersonal relationships. And that will be registered by a scale that has items such as, I don't feel comfortable opening up to romantic partners. I prefer not to be too close to romantic partners, or I get uncomfortable when a romantic partner wants to be very close. So if dynamic psychotherapy works as it should, you would find it likely that you have better scores on these scales after psychotherapy than before. And this has, to a certain extent at least, been demonstrated that it actually does work that way. You may also have, for instance, you have scales for schema therapy. So schema therapy is an extended version of cognitive behavior therapy, focusing on the core beliefs of patients, or the schemata. And then you have a questionnaire that measures 18 specific negative schemas in a 90 item questionnaire. So you would have items for instance, I feel that people will take advantage of me, which would be a sign of a mistrust or abuse schema. You have items like, no man or woman I desire could love me once he or she saw my defects, which would be significant for patients that have problems in terms of having a defectiveness or shame schema, and so on and so forth. So the essence here is that if you have a psychotherapy that focuses specifically on changing or moderating a person's core beliefs about themselves, about the schemas, then you would also want to have measures that actually focus specifically on, so how does it go? Do you have less problems in terms of problematic schemas after therapy than before? And this goes for instance, mindfulness-based therapy. There are measures for mindfulness as well. So you also have rating scales. And some of these rating scales are relevant for different types of psychotherapy. So one of the things that I've been working with myself is the reflective functioning scale. And the reflective functioning scale is actually extremely time-consuming. I just have to say that. It is a scale that requires that before you rate reflective functioning, you do an adult attachment interview. So for those of you who are not familiar with the adult attachment interview, it is an interview that asks the patient to give adjectives about attachment figures, and to give and then to elaborate on, so why did they say, for instance, that my mother was warm? Why did they say that my father was protective, and so on and so forth? And based on the linguistic qualities of the speech of the patient, you can rate to what extent the patient is securely attached or more preoccupied or dismissingly attached. But you can also rate reflective functioning. So reflective functioning scale, it codes patients, and you can actually have a score from being exceptionally reflective to being decidedly anti-reflective, not wanting to reflect about what goes on inside yourself or what goes on inside other people's at all. So to my mind, reflection and reflective functioning, also known as mentalization, would be a really interesting phenomenon to study, because as a dynamic psychotherapist, because you would expect that dynamic psychotherapy leads to better reflective functioning and leads to higher mentalization. It may be problematic, though, to focus on this as an outcome measure, because it's very difficult to administer the adult attachment interview twice. It's hugely time consuming, and patients sometimes find it rather stressful to be interviewed with the AI, and to do that twice is sometimes something that patients really do not like. However, even though we had these problems in the study that I did, we actually used the AI 3 times over a 2-year-long therapy and rated the reflective functioning. And it turned out actually that change in reflective functioning, so improved reflective functioning, was actually related to better outcome in psychodynamic psychotherapy, but not at all in cognitive behavior therapy. In cognitive behavior therapy, actually, the reflective functioning diminished a bit, but it turned out that you could actually have a diminished reflective functioning in cognitive therapy and still have great results. But in dynamic psychotherapy, a positive outcome was distinctly related to improved reflective functioning. So this, in a sense, is the proof of concept that reflection and improved access to your own feelings and self-understanding is a core change mechanism in dynamic psychotherapy. You also have, for assessment of your therapy generally, but something that may be really interesting to dynamic psychotherapists as well, you have what is called the Patient Attachment Coding System, the PACS, which was developed by Alessandro Taglia. And this is a hugely interesting measure because it identified patient attachment patterns based on transcripts of psychotherapy. So you can actually rate psychotherapy transcripts, and you can do that with any kind of psychotherapy, not only dynamic psychotherapy, but also, for instance, cognitive behavior therapy. And you can look for markers for the extent to which the client is proximity seeking toward the therapist, says things that are intended to maintain the contact with the therapist, but also whether the client is actually curious and trying to sort of think out aloud, and in that sense sort of tries to explore and reflect on new subjects. But then you can also score to what extent is the client avoidant towards the therapist, avoids having a more close relationship to the therapist, or conversely, if a client is resistant to distance. So if a client constantly wants to be really, really close to the therapist, perhaps in order not to reflect or explore the problems. This can be coded reliably based on psychotherapy transcripts, and it actually corresponds to the results from to the categories of attachment that you get from the adult attachment interview. And you can also use this, at least to a certain extent, as an outcome measure, because you can see whether the patient's discourse during therapy actually becomes more secure, which would, of course, indicate that there is a development in the perhaps more global relationship patterns of a client. So finally, in terms of these rating scales that are relevant to specific types of psychotherapy, a very well-established, relatively old measure is the experiencing scale, which is perhaps is particularly relevant for person-centered and humanistic approaches to psychotherapy. So the experiencing scale is a rating scale that describes several levels of how emotionally and cognitively you're involved in your own ongoing experience. So are you in touch with yourself, with your experience? It's a bit like the presence concept that Sherry Geller, as I understand it, discussed with you at the last seminar. So the experiencing scale goes from 1 to 7, and at the lowest level of experiencing, you would have a client that talks about events, about ideas, about other persons, but never really talks about, so what goes on inside the client? What are the client's emotions or feelings? And gradually at the higher levels, you have clients that refers to themselves but do not express emotions. You have clients that focus more directly on emotions and thoughts, up to sort of the higher levels of experiencing, where the client really explores his or her inner experience and reflects on this experience, but not in a sort of abstract intellectual way, but in a manner that shows that you're sort of deeply in contact with your inner world and emotions. So this scale would also be something that designates improvement in the sense that improvement is conceptualized specifically within, for instance, humanistic or person-centered approaches. So this is another approach to outcome measurement, to have these specific types of changes that are supposed to be essential to specific types of psychotherapy. So before I turn to the last domain, which would be what would you want to use for more clinical purposes on a day-to-day basis, I would also say that there's been developed instruments that are individualized in the sense that you ask the client, for instance, when you use the target complaints, you ask the clients simply, so what are your problems? And please rank these problems. And you ask the client typically to write down, so my most pressing problem is that I feel very alone in my life. And then you ask the client to rank, often on a scale between 12 and 0. To what extent is this is this a problem for you? How much discomfort is associated with this specific problem? And then what you can do is that you can give the client the same specific wording of the problem after treatment and ask the client, so now you've been in treatment, so how much discomfort is associated with this specific problem now? And you would know not necessarily whether a lot of symptoms have changed, but instead quite specifically what happened to the main thing that the client formulated herself as her specific problem. And a more in a sense advanced approach to individualized outcome measures have been developed by McAlevey and the Norwegian psychologist Christian Moltke. It's called NORS, and I have left the website here for those of you who would want the slides subsequently. And the interesting thing about this measure is that this is a measure that adapts to the individual client's problems. So when you start psychotherapy, you get 102 questions or items. These 102 items are loading on lots of different scales. So there are actually 23 different subscales. The thing is that after you have filled in the questionnaire the first time, then there is an algorithm that calculates, so do the client have problems on all these different domains and dimensions and scales? And if a type of problems is not relevant to the client, then you throw out most of these items and don't use them subsequently. You only leave one item. It can be, for instance, about eating disorders. So if the client apparently doesn't have eating disorder problems, then you just discard the eating disorder scale. You leave one item because then you can monitor through therapy if at some point eating disorder problems actually become active in the client. If this problem becomes active, then you reintroduce the other items that focus on eating disorders. So you have a measure, and the thing is that you can actually use this measure after each session, and then the therapist gets feedback about, so how is the progress in the client's symptoms, and only those specific symptoms where the client actually seems to have problems. And you also get information about whether new problems have actually arisen, because then the system registers that, oh yeah, the client didn't usually have eating disorder problems, but actually it seems as if she has problems with eating at the moment. So furthermore, it also includes questions about therapeutic alliance and questions about whether the patient have specific needs in therapy. And since the therapist gets a structured overview of the client's scores after each session, the therapist, to a large extent, knows, so is the client progressing as she should be? Are there specific areas where the client is not progressing? Or are there actually some new developments, negative developments in symptom areas that haven't been a problem before? And furthermore, is the therapeutic alliance okay? And do the therapist formulate specific needs that they want the therapist to address? I'll just skip the slide. And this brings us to the final dimension that I want to touch upon, which are the feedback measures. So these days, feedback in psychotherapy has become increasingly important, and probably the most used measure is the outcome rating scale, the session rating scale developed by Duncan and Miller. So these are extremely easy to use. You simply ask the client before each session to fill in to rate these 4 items on this visual analog scale. Simply put a cross closer to right if you have huge problems within this domain, and closer to left if you don't have any problems. And you ask the client simply to say, over the last week, how have you been feeling personally in relation to the family, in relation to work, and in terms of sort of general sense of well-being? This allows the therapist to get an overview of, is the client progressing, or is the client actually deteriorating, as opposed to what happened in the last session. And after each session, the client fills in 4 questions on this visual analog scale that focus on the relationship to the therapist, on agreement with the therapist on goals and topics, on whether the client actually feels that the approach and method is okay, and what the overall feeling about the session was today. So this allows the therapist, gives the therapist an impression on how are things going, and allows the therapist to immediately, on a session-to-session basis, address whatever problems there seems to be in the development of the psychotherapy. So this approach, called feedback-informed treatment, has become highly popular and is, to a certain extent at least, documented as an approach that contributes to better outcome of psychotherapy. So an alternative approach to this is the OQ45, which is somewhat more resource intensive. So this is an instrument where you have 45 items that are used after every session. And there is a software package that calculates for each client, depending on what was the symptom load at baseline, calculates what is sort of the standard recovery curve or pattern for clients that have specific baseline score. So you would expect clients to improve, but not necessarily improve at the same rate if you have very low symptoms initially or if you have very high symptoms initially. But then for individual clients, if their symptoms do not follow this positive development, if clients actually do not get better or even get worse during the treatment, then the therapist receives feedback that you have a client that do not improve as you would want them to do. And these patients that are not on track, they receive a further questionnaire that monitors alliance, their motivation for change, their extent of social support, critical life events. And then the clients receive their scores on these instruments and also some advice on how to deal with these problems. And again, this is an approach that has been documented as improving outcomes, and of course, particularly improving outcomes for patients that do have these off-track curves. So now I'm going to stop here because we're very close to the end. So I'll unfortunately have to skip my last slides. This is just a reference to a study that I've been doing myself where we have been using some feedback, but if you get the slides, you can just check out the article, there's a reference to it. So I just wanted to say to you that here at the end, I have given you some references for further reading. And if you are interested in using any of these scales, if you need specific references to them, you're always free to contact me. You can simply write me an email at this email address, and I will either give you the information myself or put you in touch with those who have developed the instruments. So thank you very much for your attention. And we may have time for just one comment or question from the audience.
Thank you so much, Steve Poulsen. This has been so stimulating, and just listening to you, I found that, this is so much within everyone's grasp, maybe also, even when you work as a clinician, that some of these scales can be used. And if we can contact, or some of the Ukrainian colleagues can contact you, it will be very, very helpful. Maybe to get some resources. Just because of time, of course, if you have questions, please raise your hand. I just want to give one note of information. We don't want to go too much over time. That is the information about the upcoming conference in Dublin, which is the conference of the Society for the Psychotherapy of SPR, so psychotherapy research. Next week, you can see it starts next Wednesday. There is actually, interestingly, a module that's also online. I know in the current situation in Ukraine, oh my God, this is difficult to travel. We have talked about this earlier with some of you, and it is now possible to actually join online. Some of you may be traveling. I heard there has been interest, and others may want to be there online. It's a very clinically relevant and really, really helpful conference, I think, if you want to learn about the updates of psychotherapy research, right? It's not just the very complicated statistics, but it's also very how you can include, as Stig Poulsen taught us today, a measurement in everyday practice. And the good news, the president of the SPR has waived all registration fees for any person from Ukraine. So if you are interested to attend, either come to Dublin next week, or you can attend online for free, right? Go on this website, psychotherapyresearch.org, and you can join us. We will all be there, I believe, Michal, Stig, and myself, and others who will be presenting our newest research. And it is for free, only for colleagues from Ukraine. It is our way to stand by you, to stand by Ukraine in this extremely difficult situation. Any final thoughts? Of course, we'll be back after summer break with another webinar. And Michal, maybe you have more information or you want to say a few words before we close. Thank you to Stig also from my end. I'm so grateful to you doing this. This is extremely stimulating. Thank you so much.
Thank you for inviting me.
Thank you, Uli. Thank you, Stig. I think it was a very interesting presentation that put together actually a vast amount of knowledge considering psychotherapy evaluation and the way it is done. And I would like to invite you for the next seminar that will be held within this initiative. The title will be Now More Than Ever, Self-Care for Ukrainian Mental Health Professionals. And this seminar will be given in September by Professor John Norcross from the United States of America. So feel free to join and also to spread the news. Everyone from Ukraine is welcome. Everyone interested in psychotherapy research, who is also clinical psychotherapist, but not only, also those who do not clinically do psychotherapy, but are interested in research can join. So spread the news. And the initial date is September 11th. And I think if we are able to keep that date, we will try to do that on that time, the same probably time as this seminar has taken place. So all of you, please feel invited. And to what Uli has said, I would like to also thank from my side, from the SPR for Ukraine initiative, to the executive committee of SPR for the waiver of the fees. And I think that it's very important, and please do join us online in Dublin. Stig has given you a very nice introduction to what SPR is all about. So if you are interested in the newest advancements in psychotherapy research, join us in Dublin. Online, it's very easy, it's well organized. So I really do look forward to seeing some of you participate. And the program is vast. If you look at the program, those are hundreds of presentations. So go on the web page. I will write the web page on the chat and take a look at how psychotherapy, the Society for Psychotherapy Research, how large it has become. Thank you.
Thank you. So this closes our event today. Thank you for your participation. You are close to our hearts, and of course, we look forward to seeing you soon. Bye.
Дякуємо дуже. Дякуємо. Це було
Thanks a
дуже
lot.
важливо і дуже цікаво.
It was extremely useful and extremely interesting.
An amazing job again. So I hope you will continue to support the Ukrainian colleagues and us also in organizing further events.
Thank you.
Thank you.
For your time. And bye-bye. Hope to see some of you online or perhaps in person in Dublin. And thank you very much.
Bye.
Bye.
Thank you. Bye.
Thank you. Bye-bye.
Thank you so much.
Они сами, блин, по-русски, два слова сказали.